So we're on week 8. I told you it's going to get rough at the end of the semester, and I think you're all seeing it. As projects due, going into third exams, worrying about HESIs and getting everything done. Homework hitting you really hard. Just remember, do one thing at a time. You'll get there. And with us online professors, just let us know what's going on before stuff is due, and we can work with you as long as we know, okay? Now this week, you have a pediatric assessment project due. It is worth 6% of your subjective grades. And today I turn those grades off. So you only have objective grades showing right now. Now, this project, what I suggest you to do is pick something that is close to you. Something that maybe you, your child, your sister, your aunt, your neighbor, your friend, something that you want to know more about, and make it personal. Let me know what you're doing for your project. I'm going to give you a warning. I know some of you have access to previous projects sent in, but it goes directly through a plagiar checker, and I will know. So if I see it, I'll just say, change up the words, make it your words. It's okay to use it, because I understand you want to, save time, but make it your words. Change it up, okay? Because I see 100% plagiarism, 99%. I can't do anything with that, but maybe you have to report it. And I don't want to do that. So hand these projects in a little bit early. Number one, get approval for what you're going to do, what your topic. Hand them in early. I will score them and I will give you feedback. If you want to improve your grade, do what I've told you to change, and I will increase your grades. And we have to do this through Sunday, which means I'll be checking this. Maybe not on Thanksgiving Day, but I'll be checking it Friday, Saturday, Sunday. And just to let you know, oh, you didn't do this, or I didn't see this section, or send this. And just follow what I'm telling you to do, and you could get perfect scores. And that can, in the end, increase your grade overall. So make sure I know what your project is. You have a pediatric assessment assignment, quiz 5. You're going to be able to do it after class today. You have your NCLEX questions and diabetes, and we know those dosage calculations. Everybody in this class has it done. So thank you so much. And I think I got a late one and I've already put it in. Is okay, no problem. So today we're going over GI/GU. I did send you a matching worksheet. Another good one that goes through those diagnoses that you really need to know. And it sort of helps you think and go as you're studying for exams. It's a deception. What do I see? Current jelly stools. Okay. Pyloric stenosis. Okay. Olive-shaped mass in the upper middle quadrant, right quadrant. Projectile vomiting. So you're going to go back and go, okay, I know this, I know this, I know this. Because when you talk about diagnoses in children, we're going to ask, what are you seeing? What's your assessment? And then what would you do for it? So think of it that way. So we're going to do our PowerPoint first, and then we're going to go to our Kahoots. It's a long night, so we got to get going. And because you're in other classes, we start a couple minutes later. So I'm going to try to get you out here on time. So genital urinary, GU, problems. Well, when you think of GU, you think of urinary tract infections, common in kids, especially for those kids going through potty training. Even infants, they stool in their diaper. It can go up into, their vagina, into the meatus, and it could create infection. So young kids are really apt to get urinary tract infections. So the other thing about children is boys. Boys have, if they're not circumcised and you don't pull back that foreskin and clean it every day, there's this schmegma that forms. And it's like a petri dish for bacteria. So it needs to be pulled back and cleaned every day. My grandson was so tight and I couldn't pull it back. he had to get circumcised within 1 month of age because I didn't want the possibilities of urinary tract infections later on. It was that tight, for his penis, and other issues could have occurred. Remember, with urinary tract infections, one thing we need to teach our parents is to make sure they finish all the antibiotics, because if they don't, that urinary tract infection will come back. And that goes with any antibiotic that we give. Make sure they finish it. Teaching our parents, how do you know a kid has a urinary tract infection? Well, if they're incontinent and they're potty trained, that's a clue. And then, of course, if you smell it, you'll see some kids with their hands down there rubbing, especially girls. It gets raw, or you see them running to the bathroom, check for it. So kids, young girls, we know that bubble baths, we know that tight clothing, they should wear cotton underwear. These things can cause urinary tract infections, and try to teach them wiping front to back. And we know young toddlers, and preschoolers are trying to do the best they can, but we're not always there to do it for them, because preschoolers go to school, right? And that's when you start to see it. Also, constipation can cause urinary tract infections. So keeping stools moving. In fact, they're not going to even think about doing more workup for urinary tract infection until we get those bowels moving frequently, because they push and they strain, and then they're sitting on the toilet and they're wiping, and that causes it. Adolescents, we can teach them, if they have urinary tract infections, if they're sexually active, to urinate immediately after intercourse, because that does help too. So how do we go and we diagnose these things? Well, we have all the assessment, all of the symptoms, but we need to figure out what bacteria is there. Now, we usually know, we think we do, and there's usually an antibiotic we choose, but we need to do a urine culture and sensitivity. Now, young infants under a year, they really don't have a big immune system yet. So letting them having an infection and just doing a bag urine, which could be contaminated, could mean that we didn't treat that urinary tract infection completely because it was a wrong antibiotic. To do the most accurate, best for this child should have a catheterized straight graft urine. And it's simple. And it really doesn't hurt, whether boy or girl. It doesn't hurt. It's uncomfortable. And again, put a pacifier, let mommy at the head of the bed, distract your child. In your premature children, they do a suprapubic aspiration because the catheter is too big. Because if you have a 600-gram baby, how are you going to do a urinary tract infection? I mean, it's going to be pretty impossible. So what we do is we clean right above the symphysis pubis, and the doctor, the needle straight down on a 45-degree angle and pulls out maybe a half cc of urine. That's all you need. You don't need a lot. And now we've got a urine, which is going to do a culture sensitivity, and we will know that the antibiotic that they received is the one they needed. And if it wasn't, we're going to change it. So we cure it one time round, not 2 or 3 and kill kidneys in the meantime, which is what we don't want to do. If we're having chronic pyelonephritis, which infection in the kidneys, we might do a kidney tap. We want to see what's going up there. Maybe we're not seeing it in the urine. Sometimes we'll put a catheter in and put extra fluid and we'll wash out the bladder, and we're going to see some different sludge in there. We could do ultrasounds, avoiding cystourethropographies, looking at where the flow of urine is going. Is there obstructions, or is the sphincter between the bladder and the ureters, putting the urine flow back up, which can cause a lot of problems. IVPs on your older kids, usually for kidney stones or a renal scan. Now, sometimes we have to do a renal biopsy. Now, very similar to cardiac catheterization, the post-op treatment. We will keep them NPO before, as according to the child and the age. these children will get some sort of pre-sedation, maybe a little bit of midazolam, just some Versed, a little bit, make them a little bit, twilight. And then of course, when they do the procedure, they'll knock them out a little bit more to keep them calm. We don't want them moving during this procedure. We'll take the vital signs when they come back, but just like we did with cardiac cath, there is a pressure dressing over it. And there's sometimes older kids sandbags, to hold it like a Band-Aid, like a finger holding it. Now we're going to check that dressing for urine and also blood. And the other thing we check, which is a little different, is their abdomen. Maybe some urine is leaking into the abdomen. So we have to make sure that that kidney is safe and just not leaking and causing other problems for going on. But just like cardiac cath, bed rest 24 hours. So that's how we take care of renal biopsies. And these kids may be completely knocked out or not, but remember, always tell them, might hurt a little bit, but we're going to do everything to make it feel as good as we can. Now, I mentioned obstructive uropathy. There could be one ureter, two ureters, could be valves, but urine's not going the way it should, not flowing down from the kidneys, and this can cause urinary tract infections. This is the picture you have in your book. Remember, a bladder is called a vesicle. So vesicle ureteral stenosis, that means something's going on between the ureters and the vesicle, which is the bladder. So understanding that, we can find out where urine could go to. A syndrome children can get is called nephrotic syndrome. I want to say it 3 times. It has nothing to do with renal failure. This is not renal failure. It's the kidneys working, saying, protein, I don't like you, goodbye. So it spills all the protein out of the body. So you'll see proteinuria because the protein goes, and then the protein or albumin in the blood also goes away too. When that albumin disappears from intravascularly, fluid is forced interstitially. That's why you have edema. These kids get swollen tongues, lips, and cheeks. Eyes will be swollen. They don't want to eat because it's so swollen. They keep biting their gums, their cheeks. So it can be a big thing. So how do we treat these children? Excuse me, my voice still wants to be crazy on y'all. These kids are immunosuppressed. They do have a risk for infection, so good hand washing and good care will be really appreciated with these. Because of the mouth and the swelling, they don't have an appetite. They don't want to eat. It's just like if you have an open sore in your mouth, you don't want to eat because it hurts. It's the same concept. Any type of diagnosis that has to do with retaining fluid, you're going to see salt restrictions, fluid restrictions, and we'll monitor it how? Intake, output, and daily weights. Any class, adults, children, fluids being retained, these are things you're going to look at. So we are going to do what? Well, we're going to try to reduce the excretion of urinary protein. These children actually get corticosteroids, to help them during the times when they're retaining a lot. It decreases the inflammation that's going on. We always, of course, prevent infection, sepsis, and of course, strict I&O and daily weights. We can see, are they losing the fluids or are they not? And these kids might get a dose of albumin and follow it by a dose of Lasix, because albumin will pull fluid from interstitial back into the vessel, and then the furosemide Lasix diuretic, boom, will help it get rid of it, and you can get rid of that fluid, that edema, a lot quicker. Does that make sense to you? Replace the protein albumin, give a diuretic, it pulls it out, and it will, you'll see that in the daily weights and an increase in urinary output. Acute glomerulonephritis is just like rheumatic fever. It is caused by a strep infection. So there's two, rheumatic fever and acute glomerulonephritis. Now we've talked about all the signs and symptoms of rheumatic fever, the signs and symptoms of acute glomerulonephritis. They're oliguric, they're not peeing. They're starting to swell because now they're retaining fluid. And retaining of fluid causes the blood pressure to go up. No matter what, you're always going to have an elevated blood pressure for that. They also have blood in their urine, and they also will have protein in their urine. This is just part of the symptoms you see. So usually children that have the acute stage, and we figure out it is due to a strep infection, and we treat the strep infection, they're good. There's some times where parents might wait too long, or the kid doesn't respond as quickly. It could become chronic, which we're trying to prevent. So early intervention, getting them to the doctor, getting them on the proper antibiotic quickly will help. So what are we going to watch? Daily weights, I&O, and it has to do with the kidneys. So we're going to do abdominal girth, to see that swelling, what's going on. Low sodium, fluid restrictions, and of course, we're going to be careful with infection control. Wilms tumor, the adrenal tumor on the boys, 3 to 5, African American. And it's a tumor, and the biggest thing, remember, is that this tumor is fragile. And if we touch it, palpate it, pieces can break off into the abdomen and cause metastasis. So these children, we're going to maybe do some chemo radiation before. We'll never biopsy. Because if you biopsy it, you've broken open and pieces of it go into the peritoneum. We don't want to do that. So you notice it's a big incision. We want it, and you have to go down underneath all the intestines to get the kidney tumor and bring it up. And we don't want to squeeze it through an opening. So it is a bigger incision. Again, biggest nursing thing. Do not palpate that abdomen. Changing diapers and bathing, be very careful. Leave it alone. Renal failure can be acute or chronic. Acute, something happened. I've seen ibuprofen cause acute renal failure. I saw BUNs go to 12. 3 days later, all of a sudden they urinated, they were fine. And that's when they determined it was ibuprofen. The kid was sick and the mother gave a little too much ibuprofen and it caused it. So it can, just to let you know. Acute renal failure could be that obstruction that we didn't catch, and it keeps going up into the kidneys, the urine, and it, it's caustic urine. So it's killing the kidneys, causing renal failure. So if we can relieve the obstruction, get it flowing, many times it'll come back. The other acute renal failure is due to dehydration. Kids do not like to be dehydrated. So we see in kids with dehydration signs, we need to give them fluid quick. Chronic renal failure is usually due to some sort of congenital abnormality. I've also seen chronic renal failure have to do with in the hospital where I was, and there is a dialysis area, they said that there was families marrying first and second cousins for whatever reason. And because of that, they were having chronic renal failure and requiring dialysis. So acute renal failure is when it happens suddenly. All of a sudden, you're not urinating. And of course, you see all the signs and symptoms, the acidosis, the electrolyte things. But remember, a lot of times acute renal failure is due to either that obstruction, but most of the time it is dehydration. So remember, how do we look at dehydration? You're going to see a kid lethargic, sunken eyes, babies not crying. You're going to see, decreased urinary output, but then your vital signs, elevated heart rate, decreased blood pressure. You start seeing that, okay, we need to get fluid into this kid. We need to flow it through the kidneys so it will work. Chronic renal failure is when 50% of the kidneys are gone. They're not working. and it only gets worse no matter what. You know, when the kids are older, they get hemodialysis, but younger kids do not. And I have a slide, and I'll go into that in a second. Chronic renal failure, as I said, it could be due to, you know, the hereditary thing, could be congenital malformations, chronic reflux going on, pyelonephritis. How about lupus? Doesn't lupus hit every organ? Sure. And of course, an anaphylaxis that is a bad one can also attack kidneys. So in renal failure, doesn't matter adults, doesn't matter children, we're basically trying to give that maximum renal function. We're trying to make it work as much as we can. We want to keep fluid electrolytes where they should, and we're going to give erythropoietin. Don't adults get that? Because you're not making red blood cells. So children do too. And it's also to make those red blood cells. You know, kids are, you know, basically slave to these machines 3, 4, 5 times a week. So the time that they're not on machine, you know, we try to make them as normal as we can. Now, I told you not all children can get hemodialysis. Infants are too small to accept the flow that returns the blood from the dialysis machine. It's too much turbulence, and it goes to the head and causes brain bleeds. So we can't. So how do we work a kidney when they have none or minimal function? Well, we do peritoneal dialysis. And you see that tube into the abdomen, that big long one? That is a peritoneal dialysis catheter. And what we do is we teach parents, or sometimes you have to have a nurse go at night, hook up a machine under total sterile, cap, mask, gowns, gloves, because we do everything to preserve that peritoneum from getting an infection. So we hook them up. There's a machine. It's heated diastolate liquid, nephrologist says, and the nephrologist will say, instill 100 mLs of this fluid. Let it sit there or still 20 minutes. And then you open it up and it drains for 20 minutes. So what you put in, it sits there and drains is 1 cycle. You might do 8 cycles. You might do 10 cycles a night. And in the morning, you look at the Foley catheter where the drain went. And if you've done 10 cycles, you had 100 mLs with every time, it's 1,000. What's over that is the urinary output. So you can measure urinary output. So our biggest concern with peritoneal dialysis is infection. How would you know it's infected? Well, usually, the first thing you're going to see is the diastolate liquid coming out changes color. It gets cloudy, something happens, or you see particles in it, it's not right. And you might see some redness or tenderness in the abdomen. That's it. So what do? Immediately, you call the healthcare provider and expect them to order the antibiotics. But call them up, let them know what's going on, and they will get your antibiotics and start them immediately. Because if you don't have a peritoneum, what's going to filter the waste in your body? There's nothing. You don't have kidneys. Your peritoneum is all infected. So you have to do what you need to do to keep that belly safe so it can do its job. And they do this at night. So these children can sleep at night normally, and kids actually do very well with it. They're starting to do this also on adults. Instead of putting them right to hemodialysis, they're doing it. So again, same thing, abdominal cavity, warm solution. Our biggest concern is peritonitis. And if we see a change in color, call the healthcare provider and get that antibiotic. And as I said, I've seen some parents work this at home. I had one child at the place where you do the clinicals at Cutler Bay. He did it for 2 years, no infections. Her dressings were better than mine, and I'm OCD on dressings. So I give her the hoorah, amazing thing. So, and she kept her kid at home. So what describes acute glomerulonephritis? What is the answer? Where does it come from?
Occurs after a streptococcal infection.
Whoop, 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 whoop. Yes, it does. Just like rheumatic fever. Good job. Okay, GI has a lot of things you've never heard of. Pediatrics has a bunch of different diagnoses, a couple that you heard of, but let's figure out what they are. And remember, you've got a great matching for this. GI is mouth to anus and absorbs all your nutrients, basically, right? That's its job. And it excretes waste. That's GI. So when we're talking about nutrition, there could be vitamin imbalances, mineral imbalances, and it can be caused for many different reasons. It could be due to an illness, HIV, sickle cell, cystic fibrosis. Remember, there's a lot to do with giving pancreatase to be able to take these enzymes to make the food and what we need. And think about a premature infant. They have extra caloric needs, but they drink less. So how are we going to take care of them? You know, and I'll tell you, we just increase calories per ounce. You know, the normal formula is 20 calories per ounce. We can give 27 calories per ounce. There's a bottled formula like that, or we can add more, depending. Celiac disease, that gluten thing, it has to do with the body has a problem with fat malabsorption, and it has to do with diet. We treat this with diet. This is the avoidance of rye, wheat, and barley flours. That means no chicken nuggets, that's no macaroni and cheese, that's no bread, peanut butter jelly sandwiches, unless it's a rice bread. You can have rice. Now, you're saying, okay, they can't have all these things, right? But they can have a lot of good stuff. Eggs and omelets and bacon and cheese and milk and ice cream and fruits and vegetables. And today, go to the bakery and look for gluten-free. You'll see it all over the place. Much better than it used to be for these children. You know, these children have that horrible smelling stool because they cannot absorb fat. So you're going to see supplements, fat soluble supplement vitamins for these children. Food allergies, you know, we start feeding our infants at 6 months old, right? We introduce foods, and before that, their GI tract don't tolerate it. But at 6 months, we give one food, and we will not give anything else to 4 to 7 days after one food. And then we can introduce another. Now, the food allergy might be just a little rash, and it doesn't have to be this pronounced like this child. It could be underneath the neck, in, you know, the crooks of the elbows or underneath the knees. And this could show an allergy, so it needs to be looked at. Common one, lactose intolerance. Sometimes if they're formula, they do see that immediately at birth, and the intolerance will be the child's vomiting or with diarrhea, and that's usually what we'll see with lactose. So GI dysfunction causes growth failure. They're spitting up their nutrition, right? It's spitting up, regurgitation. GI dysfunction could be nausea, vomiting, diarrhea, constipation, and sometimes abdominal pain, distension. If you can't digest fat, what's going to happen? Your belly's going to blow up, you know, with all this gas in it. GI bleeding can occur. Problems with the liver and obstructions, jaundice, and dysphagia. Some kids can't eat. There are two syndromes that I'll mention, Pierre-Robin and DiGeorge syndrome. They both have issues with eating, swallowing, textures of food, their tiny little chins, and the way they work. These guys need speech therapy from newborn in order to teach them. And of course, using that pacifier does help them start to learn how to suck. Sucking, swallowing, and breathing is a hard thing, and that's what infants do for the first 6 months, right? But these two syndromes, very difficult. The swallowing, they just don't get it. And fever. Ever have a kid with a fever? They don't want to eat. They don't want to drink. They want to leave me alone. That's why I always say, hurry up and medicate. Because as soon as those fever comes down, they can drink. As I said, dehydration is very serious in children. It can be due to many things, vomiting, diarrhea. It could, all of a sudden, the kidneys just putting out too much, like nephrotic syndrome, diabetes insipidus. These are things where you can get just a big urinary output. And of course, anything like ketoacidosis burns, that causes it too. Now, I love an infant that's dehydrated because I can look at their heads and their color of their skin before I even listen to a heart rate, and I can tell. That upper picture, it's classic dehydration. That kid is just sitting there, quiet, and you see the sunken fontanelle. You can even see those bones in the head. But look at the color of this child. The nose is white, the ears are white, something's going on. The bottom kid still has pink toes if you look down there. So that one isn't as bad. Now, how would I know the difference? I'm going to take my stethoscope. I want to listen to a heart rate. I bet you the upper one's heart rate is over 200, right? 140 to 160 is newborn. That's a newborn kid. That's very young. And depending on the age of the other child, it's going to be slightly elevated because I still see something. And remember, looking for dehydration, adults, children, you'll see elevated heart rate, lower blood pressure, long capillary refill, decreased urinary output, and with children, you're going to cry with no tears. It is so sad to see a baby crying and no tears are coming down and their eyes sunk in their head. That's what you see with a dehydrated infant and child. So what do we want to look at first? Well, we start the IV and I want a basic metabolic profile. I want to know where my electrolytes are, and that's going to tell me how much volume they're going to need to get better. When I give fluid replacements, I give nothing with dextrose in it as a bolus, only normal saline. And if they want to give potassium in an IV, you cannot until the infant voids or you get that potassium result from the lab. And if they're vomiting, we're going to treat it, of course. We're going to give that, Zofran. We're going to give that antiemetic and wait and then introduce slowly back liquids. So intake, output, looking at it, remember there's all of these things to look at, the urine, the stools, the vomit. Some kids sweat a lot and it's a lot of insensible water loss. Vital signs are key. That's why you know the different vital signs for different age groups. So you'll be able to tell dehydrated, not, or normal. And of course, body weight intake output is going to tell you, are they gaining or losing? Children are sensitive and you'll see weight gain and loss very quickly. I love the fontanelles. And then older kids, they're not going to be as alert. They're going to be sleeper, tired, don't want to be bothered. And that's because of dehydration. Now, diarrhea. How do we treat diarrhea? There's all different types of it. Well, diarrhea, there's no magic pill. So how do we treat it? Well, they're losing electrolytes and fluids from the rectum. So we need to replace it. If they're awake and alert and not vomiting, you're going to give oral electrolyte solution, Pedialyte, Powerade, Gatorade, and they can slow sips, they'll take it. But you have to reintroduce a diet because if you don't, only liquid's going to come out the other end, right? They used to have brat diet years ago. I mean, it's still a good selection of things, banana rice, applesauce, toast, but they don't limit there anymore. They say, start feeding your kid because then the stools will tighten up. And do you know what they're going to order for diarrhea in the hospital? A probiotic, lactobacillus, because we need to replace that flora. And I'm just telling you that because you're going to say, so how do you treat diarrhea? Well, that's all they do. There's no magic cure diarrhea. Now, constipation. Well, we already talked about urinary tract infections that really can be caused by these children holding their stool. Now, the one thing children can control is their stool. I've seen kids hold it for 7 to 10 days. And you get an x-ray and the whole rectum is white and full of stool. Their bellies are big. And it's because there's something going on. These kids know how to control it. They know they're going to get attention, whether it's something that happened at home, something they're controlling it, believe it or not. Usually it's not because of anything pathophysiological. It's usually from that, especially, your preschoolers. So how do we treat constipation in children? Well, in infants, we might give a little apple juice. It's no nutritional value, but it might stool. Or maybe a couple of spoons of prunes. That's going to help them go. And then at last, a cord, maybe a little glycerin suppository. I like just taking a thermometer and stimulating the rectum, and that stimulates them to stool. That's very benign. As they get older, of course, the diet, fluids, etc. But when they get older, they might put a laxative in. They try not to. Now, newborns. You have a newborn born and no stool within 24 to 36 hours. Very unusual. This picture is usually the first stool you see. It's called a meconium stool. It's thick, it is heat, it is black and green. That's your first stool. You should see that almost within hours of birth. Excuse me. Now, what happens? You don't see a stool. There's a problem. There's either something that's holding it back, an atresia, which means a blockage. Maybe there's a narrowing in the intestines, or there's something called Hirschsprung's, and I'm going to talk to that in a little bit. But look at this, hypothyroidism and cystic fibrosis. These are sometimes, maybe we know about a history and we're going to look for it, but if we don't, and there's no stool, we are, doing x-ray and there's no reason for it, we're going to be doing thyroid panel. Look at that T3, T4, TSH, see what's going on. And we're going to do a sweat test. Is it cystic fibrosis? Because they should be stooling. As the kids are born and they're, eating normally, some kids do have a little bit, as I said, of constipation. Younger kids don't control it yet. It's the older kids. Breastfed infants usually have very free-flowing stools. Formula infants tend to have things that are a little bit more hard. And your intervention might be to give a little prune, give a little apple juice to keep it flowing, or maybe stimulate them to let them go. Now, children can get ulcers. You have a little kid, who worries about everybody all the time. This is a child that could get an ulcer. And what is the treatment for an ulcer? Symptoms, pain in the abdomen, burning. We're going to see same things as an adult, as a kid, because these usually are your older children, preschoolers, school age. You're going to see this. They're worries. I call them my little worrier children. And we're going to treat them first with that ranitidine or Pepcid. And that's just an antacid type thing, right? What it does, it just reduces that gastric acid. And then, of course, we'll change the diet, make sure they're eating properly. But we can treat it very simply. And then we could maybe increase the type of meds, just like with adults. We're going to go to all of them. But the thing is, it's milligrams per kilogram, micrograms per kilogram, but the same meds. There's not pediatric meds. They're all the same. Children can have hepatitis. Why do we do Hep B vaccines? Initially, because we're concerned about those things. And it could be due to many different reasons. But as a nurse, how do we know how to teach parents to have these children nutritionally sound, getting the proper nutrition? Well, the liver has enzymes that help with fat digestion. So if you have hepatitis, are you getting the enzymes to be able to use that fat? or is that fat just going to sit there? So you want low fat because there's nothing to break it down. That causes abdominal distension and pain and gas, and we don't want that. That hurts. So high in protein, high in carbohydrates, and this prevents that muscle wasting, and that's the diet. Whether they're younger or adolescents, that's how we're going to treat, problems with hepatitis. Okay, here's the Hirschsprungs. This is the other constipated at birth, right? It's called congenital aganglionic megacolon. And that picture is pretty significant. You have big, bulgy intestines, and you're going to say it must hurt, right? There's no nerves. It has no peristalsis. It sits there and stretches and stretches. And sometimes you can feel it in that little infant's abdomen. So at birth, you see this. So you notice that rectum is this tiny little thing that comes down, right? Have you ever decorated a cake with icing and squirted out through the pipette thing and you see a little bit of ribbon? That you might see as a little stool. Maybe, maybe not. But usually it's ribbon stool that you might see. So how do we take care of this? This is an obstruction. It needs treatment. So we're going to do an x-ray. We're going to look at it. We're going to be doing barium enema to see how far this goes up into the large bowel. And we'll do a biopsy. And that biopsy is going to confirm there's no nerves. And what we need to do is a 2-part surgery. Initially, this child will get a colostomy. And within the first year, they will close it. But it needs that amount of rest. And of course, these children, the parents need to be watching for, bowel movements and looking for constipation. Acute appendicitis, adults, children, same symptoms, same treatment, but kids do a lot better and they recover actually quicker. So right lower quadrant pain, McDermott point, rebound tenderness, all of that. Once a kid has that and you do an ultrasound and you diagnose it, and all of a sudden their pain disappears, that appendix is perforated. So now you have a child going to surgery with a ruptured appendix. So you have taken the contents from that appendix and it's all this caustic material. It goes into the peritoneum and it creates havoc with those intestines. It makes them angry and reddened and they don't want to work because they're like, oh, I don't feel good. So these children, they do surgery and they clean it out as much as they can, but postoperatively, they're NPO. We put an NG tube down to keep the intestines empty because the stomach still secretes gastric acid, right? So we want to keep it empty. We will absolutely priority IV antibiotics. It's peritonitis is what's going on. Monitoring those lab values, looking at that white count, is it going up? Is it coming down? Pain control. These kids need to get up, get out of bed, deep breathe, cough, incentive spirometry, sit out of bed. Do not try to do it without giving them something for pain. It hurts. Their bellies are completely tender. And the wound, the surgical wound, was a dirty inside wound. So when they closed it, it's not clean pieces that were put together. So it could dehisce. So check that wound frequently because it can open up. Another thing probably you never heard of. This is called intussusception. These are younger kids, 3 months to 3 years. The youngest I've ever seen it was 5 months old, and the intestines suck up into each other. And then it could swell and not move. But many times it'll suck in, the kid screams, bends over, abdominal pain, legs are kicking, abdomen is tense. And you're like, oh, this is intussusception. You put your hand on the abdomen and it's like tense. 2 minutes later, they're in their room running around, they're fine. That means it's come out. And it happens frequently. So many times these kids are sent home on a high fiber diet. If it reoccurs and it doesn't get better, bringing them back in. But many times the pain is there. They don't get care good enough. And when it's sucked in, it swells. It's edematous and it can't pull out. So they need to do surgery and they need to remove that piece of intestines. So it could be a surgical type of intervention. So we saw ribbon-like stools with your Hirschsprungs. Intussusception is current jelly stools with maybe a little blood. So look in the either underwear or in the diaper of a child in diaper still, and you'll see like this, current, like jelly looking stuff. And you do see it when these kids are true and real intussusception. We diagnose this with a ultrasound. The ultrasound has to be done while they're in pain. Prognosis on these kids are good. I mean, these kids are in so much pain, the parents can't ignore them. They have to come in for treatment. Meckel diverticulum. In the small intestine, there's these little patches of tissue called a diverticulum. But what's inside that is a blood vessel. Sometimes they tear and it causes bleeding in the GI tract. You might have a little bit of abdominal pain, but the big thing that you're going to see is painless rectal bleeding. You're going to see red blood flow. So they find it out, what's going on. They do surgery. These kids do well. But it's this rectal bleed and it's bright red because it's a lot of blood that comes. They got to go in and get that diverticulum out. IBS, mouth to anus, anywhere in between. This is what we call inflammatory bowel disease. There is ulcerative colitis, which is segments, and Crohn's disease. It is caused many times by inflammation, autoimmune, something going on. We treat it with diet. We treat it with steroids and getting them proper nutrition with the diet, keeping it so that this foods are not upsetting these children. There are kids with ulcerative colitis, Crohn's, they might be on a biologic, Humira, Enbrel, Remicade. It could be one of those if they are one of those kids that's really, really severe. If that bowel becomes very inflamed, sometimes they do have to remove it, and that would be a segment taken out. Short bowel syndrome, this usually happens in your infants when we're feeding them and all of a sudden their bellies blow up and their intestines didn't like the food, couldn't tolerate it, and the intestines die. And it's called necrotizing enterocolitis. That means in these infants, that's why we measure abdominal girth every time we feed them. If we see an increase in abdominal girth, then if we see like loops on the abdomen, we will not feed this child. We're going to do an x-ray and that's where we find it. I had one girl who was post-op cardiac surgery. She had 58 centimeters of her small bowel removed. She had about this much left. Just enough for the common duct to spill stuff in. So her nutritional status was pretty bad. She's about 22 years old right now, so she did okay. What did they do? Exactly what this boy looks like. They put in a G-tube to be able to give feedings, for supplements. They also did hyperlipids at night. And this girl was able to eat whatever she wanted by mouth, but she couldn't eat enough to keep up with it. So that's why they gave her the other stuff, which is easier digestible. Sometimes you have the mid portion of the abdomen doesn't close. Sometimes the stomach is born on the outside. It's still connected everywhere, but it's not in the belly. And what they did is called gastroschisis. I've seen several of these in my career. Surgery comes, tries to push it in little by little every day. Belly's abdomen is up in the air. They only leave them on their back and they push it in, and finally they close it up. It could be with a stomach or it could be with a bladder, and bladder is called a bladder exstrophy. The body parts work. What is our job? Well, if a body part's on the outside of the body, we need to keep it clean and sterile, right? Our is to protect it from infection and keep, the tissue good. Hernias. Have you ever seen an umbilical hernia and you push your finger in and out and they're soft and spongy and it's fun, right? We have younger kids with umbilical hernias, older gentlemen mostly. It's the inguinal hernias, and they're non-painful. Well, if all of a sudden they become painful, reddened and hard, that means it's twisted. That means there's no blood supply going to that intestines. It's an emergency. They need surgery, and they go in, untwist it, put a mesh, and put it back where it goes. Now, a congenital thing that happens is what we call a diaphragmatic hernia. The diaphragm didn't form all the way in between the chest and the abdomen. And a piece of the intestines goes up to the left lung and smushes it over and pushes against the right lung. The left lung never forms. So at birth, you only have a little piece of a lung to oxygenate. These kids are very sick at birth. They're on high-level ventilators. Many of them are on ECMO, which is like a heart-lung machine to give them oxygen. And they actually usually do surgery at the bedside. These kids are very unstable. And they push it back, put a mesh, but they'll never have a left lung. Malrotation of volvulus is something that happens congenitally. Sometimes we see it, earlier. Sometimes it might be 2 years, 3 years old, they see it. Sometimes the intestines go around a artery and it impedes it, so it lacks blood supply. And then the area perforate and cause peritonitis. Volvulus is when it could tie in a knot. I mean, you've seen umbilical cords tied in a knot, right? Well, the intestines can do the same thing. Children born, one of the first things you're taught in OB is to take a rectal temperature, because you want to check a really good temperature, right? No, they're making sure they have an anus. This child does not have an anus, and it does happen. In my career, I never saw one. They're very infrequent, but they do happen. So our treatment would be, I need a colostomy. We still have juices going on, so it needs to come out somewhere. So they will have surgery with a colostomy made. And there's no way to make an anus, so they'll have it for life. One of our inspections, as we're looking at genitalia on your newborns, is looking at the vagina, seeing if there's any liquid coming out it. I've seen stool coming out of, vaginas. I've seen urine coming out of rectums, and those are fistulas. So we really need to make sure that we check and look to see where things are coming from, because there can be these aberrant connections. Now, infants do vomit in all different ways. Vomiting could be just a dribble, or it could be across the room. And depending what that is, depending on what you're going to do for this child. I mean, you have many kids that are vomiting because they have, a gastroenteritis. Their stomach is upset. They caught it from their brother, whatever, and they're vomiting and vomiting. Now, if a kid is vomiting, you cannot give anything by mouth. They're just going to vomit it. So these kids need an IV. Remember, whenever you're suspecting vomiting, dehydration, your important priority is that metabolic profile. You want to know where you're starting at. And again, with IV and vomiting, of course, an antiemetic, giving them IV with saline, no dextrose, and you don't add potassium until you know what it is, or until they urinate. And nothing by mouth until we let that antiemetic work. Children eat everything. And I'm saying anything from rat poisoning. The most popular actually is Flintstone vitamins. They love them. They find them and just eat them. And actually, of all the substances, what you don't need in vitamins, your body get rid of, unless it has iron. And we know, excuse me, we know iron can be dangerous. So if it's iron, we're on alert. If it's rat poisoning, we're worried about blood coagulopathy. It acts like Coumadin. It thins the blood. Kids chewing on windowsills in old buildings, again, that's lead. So we need to give our parents the number for poison control, you know, in case something happens. And they usually send them to the ER, and then we call in as nurses and we find out what's the up-to-date treatment for it. Reflux. Children have reflux, kids and infants, they'll vomit, right? Older kids can have reflux. And what would we see in an older child? They're going to have a cough because they're almost aspirating. When you want to aspirate, you because it's almost going into your lungs. And you'll have that burning in your chest, and you'll see that heartburn. How do we treat it? Well, Zantac, Pepcid, number one, and then we'll go through all of the medications. Now, if the kid has really bad reflux, medication is not treating it. We can do a surgical intervention called a Nissen fundoplication. You're also going to see that done with any child, usually has had a gastrostomy tube. They pinch over the end of the stomach so you can't get fluid go back up into the esophagus. So it eliminates reflux. They don't vomit because they can't. These kids cannot vomit. A hypertrophic pyloric stenosis. Remember I said there's the dribble vomiting and then there's vomiting across the room. Well, a hypertrophic pyloric stenosis is the sphincter that empties into the small intestines. It's muscular. And formula, breast milk can't go down. So the stomach fills up and then all of a sudden it can't handle anymore. And it is across the room. I'm talking 12 feet away. It is, I'm like, get the garbage can and catch it. I mean, watch your feet, it's coming. So what do you see? So if I'm asking the parent, is it this way or out? If they're telling me it's going like that, I'm going to take my hand, I'm going to put it underneath their breastbone, and I'm going to feel like a little marble, a little olive right there in the middle or a little bit to the right. And that is the pyloric sphincter there that's all thickened and you feel it. So what do? They're hungry. They're not getting nutrition. So you can feed them all you want, but they're just going to vomit more. So make them NPO. You don't want them to aspirate. They've already vomited how many times before they got to you. And we will start IV fluids with some dextrose in it because these kids are hungry. They're not getting nutrition. These children go to surgery. They open up the pyloric sphincter. They open it up. The kids have a great outcome. And usually they're home by the next day. They start clear fluids the next day on these kids and they'll go home and they do really well. So there's GERD, there's reflux, and then there's pyloric stenosis, projectile vomiting. Kids can be born, this is the GI, it's the mouth, right? They can have a hole in their lip, cleft palate. It could be soft, hard palate. Our goal is because, you know, kids are self-soothing by their mouth, you know, by pacifiers, those non-nutritive suckers, right? So we try to close the lip within 2 to 3 months of age. It is a plastic closure because we want everything lined up. So they put this, what we call a Logan bow here, so they can't swish their lip into the bed or into pillows or whatever's on their, you know, mattress, because we want to keep it protected. Also, if you notice, we have elbow protectors on this little infant to prevent them from touching it. The palate, soft, hard, We like to close it between 6 to 12 months before they really start talking, because they don't close it, they can't pronunciate. So we want to get it fixed as soon as we possibly can so that their speech will not be affected. Eating is a big deal. Lip, palate, they still need nutrition. It doesn't mean they need NG tubes. They still have a desire to suck. To breastfeed, that parent's going to have to squeeze their breast into their mouth as they're sucking or look like they're sucking. This bottle, a Haberman bottle, was actually made by a parent, by a mother. And that little upper part, you turn the bottle over, formula goes in, and it's really soft. And you put it in their mouth, and slowly you're pinching it as you're squeezing it slightly, and they eat really, really well. Because remember, no food, no nutrition, the kid's gonna be cognitively delayed, and of course, growth failure. And a tracheoesophageal fistula, or is what we call esophageal atresia. Well, remember, atresia means nothing. That means esophagus goes nowhere. Esophagus to nowhere. It doesn't connect with your stomach. So you put food down, anything down, it just comes back up. There's no place to go. And where will it go? Into the lungs. Tracheoesophageal fistula, the trachea and the esophagus are connected. So if you eat, food goes directly into your lungs. Number one thing, kids are born, you're going to suspect they're going to turn blue, they're going to be foaming at their mouth, and they're going to be coughing because they're going to be swallowing their own mucus, which is causing aspiration. So this is going to clue you in. So NPO, number one, elevate the head of their bed and suction at the bedside. We try to keep the mouth clear as possible, but NPO, we are going to start an IV on these children for the NPO, and because they are, no matter what, there's, that phlegm in their mouth, they're going to swallow some, they're going to aspirate. So we put them on antibiotics prophylactically so that they don't get aspiration pneumonias. These kids are normal kids. There's nothing wrong with them. It's just the connections weren't the way that they should. Any questions so far? I told you a lot of different things in GI, aren't there? And it's just got to think, okay? Remember the symptoms. Those are the important things. And how am I going to treat that kid? So who wants to get a cahoots tonight? Anybody in for a cahoot? Oh, yeah, let's see. Yeah, Ulysses. Amber, how about you? Data? Uh-oh, Victoria's on the move. All right, let's get going. Here we go. GIGU, week 8. A multi-select. All of the following are symptoms of dehydration in an infant. So when you see dehydration, you're going to see that visual. You're going to see that dry, pale skin, like I showed you, the elasticity, or even tenting, you'll see weakness, lethargy. What are the other things? Elevated heart rate, decreased blood pressure. You're also going to be seeing decreased urinary output. And then, of course, that mentation for sure, especially older children. What is priority treatment for a child with dehydration due to profuse vomiting? What are you going to do for that child? Remember, dehydration isn't good. Priority. Dehydration, red alert. And let's give IV fluids. To get his vomiting, you can't give them oral anything. Rest that stomach, give that antiemetic, give those fluids, and they'll actually perk up just on fluids. What is a treatment for an infant with diarrhea lasting for 4 days? What did I tell you about diarrhea? So with diarrhea, they have the ability to eat and drink. Let them eat or drink. The only time you need an IV fluid is there to the point of lethargy, so it's patient condition. But most of the time, we will introduce an infant with Pedialyte, an older kid with Gatorade or Powerade. And of course, we're going to tell them to start that diet, feed it so that there's some bulk in that stool. What acid-base imbalance may you see with a child that's having profuse diarrhea? Now, you all know that I'm going to give you some sort of ABG question every single cahoots. As I told you, your HESI has at least 3 or 4 of them every single semester. So you need to understand them. So let's look at this one. Profuse diarrhea, which means something's coming out of the rectum. We know enzymes are alkaline. So you're losing alkaline out of the rectum. So what is left in the body? Acidosis. So it's metabolic acidosis. Now I'm going to give you, I'm vomiting. We have acid in our stomach, right? Acid is going away. What am I left with? Alkalosis, metabolic alkalosis. I hope that helps you remember the differences because I try to make you think that way. A multi-select. An infant has not passed the meconium stool in the first 24 to 36 hours. What would you assess for? No stool. So the thyroid, CF, and Hirschsprung's are the big 3. I mean, when we're talking about stooling, electrolyte imbalance, that is far from what we're worried about because it doesn't cause constipation. The other 3 are those things we're going to look for. So we'll be doing x-rays, we'll be doing blood tests, we might even do a sweat test. Deficiency of vitamin D causes. We're talking GI, and we know it absorbs those minerals, and vitamins. So we need to know what the names of vitamin deficiencies are. Vitamin deficiency is called rickets. Vitamin C deficiency is scurvy. Like the sailors on the boats years ago, they had scurvy because they didn't have oranges, right? That's the way I remember scurvy. Multi-select. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? So now you have both. What are you going to do? What part of that question gives you the answer? And we want to give IV fluids. They can't eat or drink. We're not going to force them. No. And of course, we need that metabolic profile. We need to know where we're starting from. How severely dehydrated are we? How quick do we have to replace fluids? Multi-select. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? Remember, if this ruptured, think about the bowel contents that just went inside that peritoneum. Think about those angry intestines. Think about that infection that just went in there. So IV antibiotics, NG suction, remember, to keep the intestines empty, okay, because they're angry. And of course, we're going to watch that surgical site because it was two dirty pieces put together because that peritoneum is all infected. So it could dehisce. So believe bed rest? Absolutely not. These kids need to be up and out of bed the same day because we want to prevent any sort of complication. Passage of urine usually at night in children who have voluntary bladder control. What would that be called? And that is called enuresis. Now, I'm going to introduce something else that's not in the PowerPoints, but I'm introducing it now. Epispadias and hypospadias. It's in the male child. Epispadias, usually the ureteral meatus is at the end of a penis, right? Epispadias, it's somewhere on top, okay? Hypospadias is somewhere on bottom. So they're urinating, some different crazy way. Usually, before they're potty trained, they will take the foreskin and use that tissue in order to get that hole back up to the end of the penis where it belongs. After surgery, they put a catheter in there, like almost one that you use for a straight catheter of a female or an infant. It's that little 8 French tube thing. They put it in there. Our job is to keep it inside the diaper to measure urine. We don't touch it. It's to keep that lumen open. And they splay this penis open to do this. So this is a general anesthesia, a big surgery, but the kids do well. But they like to do it before they're potty trained. So there's dorsal and ventral, epispadias, hypospadias, okay? In males. A multi-select. What is Hirschsprung's disease? So Hirschsprung's is that big mega colon, right? That means nothing's moving, completely obstructed. Very little bit of stool goes down, maybe a little bit of ribbon, right? But there's no nerves. So there's no peristalsis, there's no feeling. How do we take care of it? We take it out, put an ostomy, and replace it later, 2 stages. A multi-select. When teaching parents about Hirschsprung's disease, the nurse would include what? So we know it causes an obstruction. We know that all the time now they're going to have to monitor their bowel habits, but it is that 2-stage surgery. We do not treat this with laxative and enemas. It's surgery, okay? Laxative, there's no peristalsis. It's not going to move no matter what you do. What type of stools would an infant with Hirschsprung's disease have? I always tell you to remember that facing thing that you pull out and you decorate a cake with, because it looks like that big tube with a little opening. Okay. What is a condition that occurs mainly in children when the intestines telescope into itself? And then I'm going to ask you, what is something you would look for in that child's diaper? Or what would you see in their underwear?
Stripe of bleeding.
Jelly stools.
Current jelly stools. Excellent. Very good. Good job. These are symptoms that you see. We've seen these on the Hessies. We've seen these on NCLEX. Those are things that they're looking for. Gastroesophageal reflux disease. What's that? So it's that flow from the stomach up into the esophagus. Remember, younger kids that, you'll see the burning and you'll see them vomiting. As they're older kids, preschoolers, etc., you'll see them coughing because they're almost aspirating and that complaining of heartburn. And we treat it just like adults, same medicines. Inflammatory bowel disease involves what? Any part of the intestines, okay, as I told you, mouth to anus, any part of it. What would the nurse be looking for where the patient has Meckel diverticulum? Remember, this is that little outpatching in the small intestines, and it rips. And there might be some tenderness in the abdomen, but the one key thing you see is that painless rectal bleeding, okay? You're not going to see distension, maybe a slight tenderness. That's about all they complain of. A child goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority? As in, what do you need to know? What's my first question I'm going to ask? What am I going to do? So I want to know where the pain is. I want to know what it is. Is it an appendix? Is it a bowel obstruction? Is it what? And according to where it is in the abdomen, we can figure out what's more of an emergency or not. Okay, so description of that pain is key. We need to know that. What would the nurse expect to see in an infant with biliary atresia? So between the liver and the common bile duct, there's no connection. Think about, what does the liver do? What does it secrete? Why is it there in the small intestines? Has to do with nutrition and digestion, right? So if you don't have that bile coming down, you're going to have these very pale stools or gray colored. And because now you are not being able to digest fat, your bellies are going to be all distended. So that's the way you think of it. You have even like tea colored urine. And of course you might see jaundice that, progresses and goes on for a while. What structure of the mouth can be impacted by cleft lip and palate? Usually I've seen lips and palate. And one time I saw one child who only had a palate, and it was soft and hard, and it was the whole thing. And that kid had a hard time eating. But cleft lip palate can be anything, 1, 2, or all of them. Cleft lip repair is done when? When you're thinking of infant and their lips and understanding that these children self-soothe in their mouths. So that tells you we need to do that quick, right? So that's how you remember the differences. Palate, lip. What comes first? The lip. 2 to 3 months. So when is the palate done? And remember, Cliff, palate has to do with speech, and we want to get it done really before they start talking, so there's no speech impediment. And that's 6 to 12 months. So lip, 2 to 3, cleft palate, 6 to 12. Esophageal atresia. Remember the word A means without. Osis means an opening. So atresia means the esophagus goes nowhere. So there's no opening to the stomach at birth. And again, remember, they're going to aspirate. So NPO of suction, elevate the head of the bed. What are the classic signs of esophageal atresia and tracheoesophageal fistula? So these kids are going to be cyanotic, choking, and coughing. Now let's look at these two other things. Olive-shaped mass, right upper quadrant, visible peristalsis, vomiting, pyloric stenosis. Current jelly stools, that's your intussusception. Okay, those are symptoms, signs that you need to remember. A multi-select. A neonate with suspected tracheoesophageal fistula, nursing care should include what? What is a tracheoesophageal fistula? It's an abnormal opening in the trachea and the esophagus. How are you going to treat that? Elevate the head of the bed. We are not going to feed these kids. It goes in the mouth and right into the lungs. And we're going to give IV fluids with antibiotics because they're having many aspirations only on their own secretions. Nothing in their mouths. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? From what you've learned today, what do you think this is? Gastroesophageal reflux. Good job. What is ranitidine, Zantac, used in a child with a peptic ulcer disease? What is it used for? Ranitidine, Zantac, Pepcid. It reduces the gastric acid production. Less acids, less burning the stomach. And of course, we're going to put them on a diet also with that and monitor them closely because kids do get ulcers. Signs and symptoms of hypertrophic pyloric stenosis. What is it? So that's that little olive-sized mass in the midline right underneath your breastbone, maybe a little bit to the right, and you could feel it. You know, these children are vomiting. There's can't go down, so it comes up, and you could feel that little olive-sized little mass. Signs and symptoms of hypertrophic pyloric stenosis. What else? Olive-sized mass. And what else will make you look for that olive-sized mass? I call it a marble. Same thing. Projectile vomiting. Now, these kids are hungry, so their appetite is great because they're not getting any nutrition. It's not going down. They're vomiting it. So they're crying. They're so hungry. So it is great appetite. It's not a poor appetite. Preoperative treatment of pyloric stenosis includes, you figured out this kid's vomiting across the room. They did the ultrasound. They see the pyloric stenosis. How are you going to treat these kids? Nothing to eat by mouth because you're just going to vomit again, but we need to give IV fluids, especially with some dextrose, because they have not been getting nutrition, or it could be a day or more that they've been vomiting like this. What does celiac disease affect? Remember, celiac disease is a nutritional problem. Which one of these works with nutrition? Think of it that way. It's the small intestines, right? The villi in there, and it creates problems, and it has to do with all the absorption of the food. So celiac, nutrition, think small intestines. If you have celiac disease, what should you eliminate from your diet? Wheat, rye, and barley. You can have rice, but wheat, rye, and barley, no. I mean, there's so many food choices today with them, so, you know, it's better than ever. A multi-select. Vitamins that children with celiac disease are prone to lose are, remember those foul-smelling stutteria type of stools that they stink. They're really foul-smelling. So it's all the fats, okay? A, D, and K. Vitamin C is water soluble, so it's the other ones. What foods would you select for a child with celiac disease? Remember, wheat, rye, and barley. Can't have those. As I said, no chicken nuggets because it's breaded, or macaroni and cheese. And then not bread at all. So bacon omelet, bacon glass of milk, perfect, and an ice cream for dessert, absolutely, or something else, whatever they like. No bread. Phimosis. Don't cover it in the PowerPoint. I need to mention it. This was my grandson. He was born this way and required a circumcision. I mean, if I cannot, do this to a child, there's a problem. And it's that foreskin was too tight and it wouldn't come down, because we need to teach parents on all male infants, pull it down and clean it at least once a day, because it does build up bacteria and it will cause a urinary tract infection. What is a hydrocele? One of the symptoms of this is, number one, incontinence and testicular pain. Treatment is usually a shot of Rocephin for adults or antibiotics for children. It is a painful testicle and there's fluid there. And even adults will have a period of incontinence. They're like, whoa, I'm too old for this. What is cryptorchidism? So cryptorchidism, the testicles are up into the abdominal cavity. Now, One of the things that pediatricians do, besides looking at the hips and whatnot first visit, is they check for testicles to make sure that they are in the sac. Now, if they're not, they'll be following that. But, you know, males, if it's cold, they suck up in, right? So if we want to get a really good, valid examination, we need it warm. So at least they're going to try to hang down, right? And if we find that a visit, it's up, they don't feel it, you know, it's good to know, was it there down before? Is this something new? Because there's a difference in treatment. You suspect an infant has cryptorchidism. How would you examine this infant? So we want those testicles to hang. So we want a warm room, right? Just like that. You can't hold them and shake them down. It doesn't work, you know. But a warm room does work. It makes a difference. Hypospadias. On top, epi, bottom, hypo. So which is it? So hypospadias is on the ventral side, dorsal side is your epispadias. And remember again how we treat that. We need that foreskin. Now it makes a difference in some face. Think about the Jewish religion. They do brisk on whatever day after birth. So not having to leave that foreskin can be a big deal for some cultures. A multi-select. How is the hypospadias corrected? So we're going to use that foreskin and we put that stint in post-operatively. And our care of that is leave it alone. Just keep it in the diaper because it's going to drain urine. The doctor will remove it 7 to 10 days post-op. What is bladder exstrophy? It's like gastroschisis, right? Bladder exstrophy. I've seen gastroschisis many times, 5 or more. Bladder exstrophy, I've seen once. So it doesn't close right. It happens during development and the bladder's up. So we always remember infection control because this is your insides on the out and they have no immune system. So priority nursing care for an infant with bladder exstrophy would be what? You know, remember, these body parts born on the outside of the body because the midline didn't close doesn't mean they're not functioning right. They still do. The stomach is still a stomach. The bladder still works the way it does. But it's the tissue. We worry about the integrity. It's exposed. Keep it the way it should be so that we can get it back in there. And of course, keep it infection-free. What are the clinical manifestations of nephrotic syndrome? Remember, this is not renal failure. Hypoalbuminemia or low serum albumin is the same thing, right? Good. And of course, peripheral edema. We have to, of course, with fluid balances, salt restriction, fluid restrictions, iron daily weights are imperative for nurses. That is your care. Children with nephrotic syndrome are often given which medications for fluid overload? Remember, they have a lot of interstitial fluid going on because there was no albumin intravascularly, so it's pushed out. So how are you going to suck it in and get it out of the body? And then how do we know if it worked? So we give albumin, follow it with a Lasix, and then we know it works because we see an increase in urinary output. What is used to treat nephrotic syndrome in children? I mean, we have a med to treat it, but remember, it also involves that low salt. It involves fluid restrictions, and it does require nurses and parents at home monitoring daily weights. And it is prednisone, okay? It's not an infection. It's not pain. We give prednisone and then we do the other things just to monitor it to see, are we getting the fluid out? A child is admitted with acute glomerulonephritis. What recent illness could validate this finding? So this is pharyngitis, just like rheumatic fever, and we treat it, we treat the strep infection. What is the priority nursing care of a child with nephrotic syndrome? Daily weights. Okay, daily weights, priority. I mean, intake and output go along with that, but daily weights will really tell you what's going on with that child. Are they losing? Are they gaining? Staying the same? Why is erythropoietin used in chronic kidney failure? Same thing for adults as it is in kids, why we use it. Because it increases the red blood cell production, because we want to decrease the amount of blood transfusions we have to give anybody. So that's just one way to do it. A multi-select. A child with chronic kidney disease can have renal osteodystrophy. What can do this to the child? Osteodystrophy, osteobone, dystrophy means there's something going on there. So you're going to have skeletal abnormalities and growth retardation. It has to do with vitamin D and also high parathyroid levels. Remember last week, parathyroid, what does it do? It regulates calcium. Too much calcium can cause these things. So it's something that we do look for and monitor in chronic kidney disease. A diagnostic finding of acute glomerulonephritis may be, you can do a lab test to find out the acute glomerulonephritis. Was it caused by a strep throat? And it's what we call a positive ASO titer, anti-streptolysin. So what it does, it measures the strep in the blood. So if we don't know if the kid had a sore throat, maybe they were staying at grandma's or an aunt's or whatever, you don't know, don't remember, we can pull a lab value and we can look and see. Which complication of peritoneal dialysis is most important? So the worry is all you have is a peritoneum to do anything to get rid of the toxins in the body. So abdominal peritonitis is something that we need to be on alert for and look for. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? You know, I had this 9-year-old boy come into triage playing hide-go-seek. He's running around the corner sort of backwards, and the back side of his back, right at the site of the kidney, was this huge ecchymotic area. And When they pulled the lab results on this child, his potassium was over 7. He had a fractured kidney by the amount of force that he went against that itch. So potassium, kidneys, always put those two things together. A multi-select. What should the nurse anticipate for a child who just had a renal biopsy? Remember, I told you very similar to your cardiac cath, but it has to do with kidneys and urine. So we're going to monitor intake and output, look at that dressing, see if there's any urine, make sure it's a pressure dressing, and they're going to be bed rest for 24 hours. We are also going to check the abdomen for any distension because some urine could leak in there too. And then you would feel a pain there with urine leaking in the abdomen. What would you do if the fluid draining from the peritoneal dialysis has changed color and now it's cloudy? Remember, these are your young children, your young infants, up to like 2 years old or so, sometimes 3. And that's all they've got is their bellies. So if it's changing color, you're suspecting infection. Notify that doctor now and anticipate he is going to order antibiotics. What would the nurse provide to an infant that cannot eat normally? They're NPO. They are not allowed to eat formula, breast milk. But what do we need to do and provide for growth and development? Your last question. Give them a pacifier because, again, remember, they self-soothe through that. All right, let's see how we did. Number 3. Yolasi, yes, good job. Number 2, Yanni. Number 1, JDY. Is that Jada?
Yes,
Jill
ma'am.
and JC. Good job, guys. It's a good cahoots. I think it really, really covers what you need to know. Please sign your attendance attestations. Remember, I will look at your pediatric assessments and give you feedback. Please, when you turn them in and you see a number there, please go back and read the comments. And I'm telling you what you need to do to change it, to improve your grades. You can turn it back as many times as I turn it back to you up till Sunday, so that I do want you to get your best grade at all possible, okay? Happy Thanksgiving, everybody.
Happy Thanksgiving, Professor.
Professor, I have a question.
Oh, me
Yes.
too. Go, Chris, first.
No.
No, I was